Good evening, everybody. I'm Ira Savetsky, PRS Resident Ambassador from NYU and Chief Resident here at NYU. Welcome to PRS Grand Rounds. As a reminder, we put together a great collection of articles which could be accessed for free at PRSjournal.com. PRS Grand Rounds is in its second year, and we've been very fortunate to receive two national publication awards. Thank you so much to all the lecturers and participants. Specifically, thank you to Dr. Samuel Lin, Dr. Peter Rubin, Dr. Mark Clemens, and tonight's lecturer, Dr. Eduardo Rodriguez. All the articles and all the lectures and article collections have been archived at prsjournal.com. And on behalf of my co-resident ambassadors, Nikki Phillips, Francesco Egro, and our editor-in-chief, Dr. Rod Rourke, thank you so much to everyone who has made this award-winning initiative possible. It is my great pleasure to introduce Dr. Eduardo Rodriguez, who will be talking tonight on face transplantation, current state, and future directions. He is the chair of the Hansjörg Wyss Department of Plastic Surgery and the Helen L. Kimmel Professor of Reconstructive Plastic Surgery at NYU Langone Health. Prior to coming to NYU, he was at Johns Hopkins and University of Maryland Shock Trauma, where he was the chief of the Division of Plastic and Reconstructive Surgery, Craniofacial Surgery, and Professor of Surgery. Dr. Rodriguez has performed 3 transplants to date. In 2012, Dr. Rodriguez and his team in Baltimore performed what was the most comprehensive face transplant at that time. And in 2013, Dr. Rodriguez came to NYU. He established the vascularized composite allotransplantation program here. And in 2015, Dr. Rodriguez and his team performed the most extensive face transplant to date. In addition, it was the first face transplant to occur in New York State. As many of you are familiar with, most recently, earlier on this year, Dr. Rodriguez and his team performed what is considered the most technologically advanced face transplant. In addition, it was also the shortest time period that a face transplant recipient received a face transplant from the time of injury. We are so fortunate to have Dr. Rodriguez with us this evening. He is truly a world expert on this topic, as well as leader and pioneer. As a reminder, please ask questions by commenting on this Facebook Live video during the lecture, and there'll be a Q&A period immediately following the lecture. Without further ado, Dr. Eduardo Rodriguez.
Thank you, Ira, for the kind introduction, and I'd like to thank Dr. Rourke for the opportunity to be coming to you live tonight from New York City at NYU Langone. It's important to reflect on the history because that gives us an idea of the direction that we're going into the future. And if you look at the timeline of the field of transplantation, it began with one of our forefathers, a plastic surgeon by the name of Joe Murray, in 1954. And for this remarkable scientific discovery, he was awarded a Nobel Prize. Now, a lot has happened since 1954, and even if we look at our own institution of NYU, Joe Murray had a close relationship with John Converse, and John Converse, in his infinite wisdom in 1954, organized the first International Congress of Tissue Transplantation. And the inception of this field began in plastic and reconstructive surgery. Now, there were some limitations, and most of them were related to limitations of medications. But if we look at what's happened since 1954 with the inception of immune suppressants, it ultimately led in 1998 to the first vascularized composite allotransplant, in this case a hand transplant that was performed by Max du Bernard. If we move the clock forward to 2005, it led to the first face transplant, once again led by the French team, by Max du Bernard and an oral maxillofacial surgeon by the name of Bernard Duvauchel. If we look at this remarkable case, and I reflect on my own career, there's no way that I could ever achieve the result that they achieved with one operation in a face transplant. Multiple procedures of conventional approaches would never have achieved the quality of the result that they were able to achieve in one operation. It's important to reflect from one of our forefathers by the name of René Lefort at the beginning of the 20th century, where he wrote, "I'm eliminating one category of fracture from this study. Gunshot wounds. These are veritable explosions in the face and are without surgical interest." And as a matter of fact, most of these individuals that had self-inflicted gunshot wounds, of which were devastating in nature, were kind of swept away. It wasn't until 2010 where Juan Barret from Barcelona performed the first full face transplant on an individual who sustained this type of injury from a self-inflicted gunshot wound. And once again, in one operation, he was able to substantially change the direction of this individual's life. It was a composite transplant, which not only included the overlying soft tissues, but also the midfacial skeletal structures, as well as the mandible and the associated teeth. Since that time, I've had a personal journey of my own trying to improve the quality of the results. And we've been able to take advantage of some remarkable instrumentation. And in this recent publication, you could see our entire team, as we go through our rehearsals prior to performing the clinical transplant, we try to take advantage of every potential tool that we use in reconstructive surgery to provide benefit in the field of face transplantation. And here we are as a team collaborating, taking advantage of intraoperative navigation, which ultimately we'll use together with cutting guides to try to improve the quality of the results, ultimately reduce operative time, and hopefully translate into a reduction in hospital stay. Through the journey and through the process, we've been trying to improve how it is that we do these operations. And it's not an operation that we perform routinely. And therefore, it takes a comprehensive process of practicing. In this particular, these two specific articles, we try to develop a protocol using cadaveric dissections. And I do feel that these cadaveric rehearsals are very important. It gives us an opportunity to define and devise a specific operation for a designed deformity in a specific individual. And through this educational process, we're able to rehearse and also eliminate what could be potential drawbacks. As a team, we review together after we perform the cadaveric rehearsals, and we refine the operation for the next rehearsal. We do these operations so frequently in a manner that we can actually end up doing this in our sleep. And that's the way we want to do it. So the day that the clinical face transplant occurs, every team member knows exactly what they need to do. With the first face transplant that I performed in Maryland, we performed about 15 concurrent rehearsals with the recipient and the donor team. When I came to New York and we performed the different operation on an individual with a total facial burn, we performed close to 10 cadaveric rehearsals. Although we can practice an operation in cadaveric tissue, nothing simulates the true procedure like a facial procurement. And this, I thought, would be a very instrumental exercise, because this would be the first time that we would be working with solid organ transplant teams. You also have to keep in mind that these are individuals that are responsible for the quantity of life. The organs that they will be procuring on that day have to be done in a timely fashion. And as plastic surgeons coming into this new field, we have to ensure that we can procure a face safely in a manner that will not compromise life-saving organs. But by the same token, it also instructs us as surgeons that are going to be removing a face in order to place a transplant, ensuring maximal safety for that patient. In a patient that's undergoing a face transplant, there's always a point of no return. We have to make the deformity far worse before we can actually transplant the procured face. We need to ensure maximal safety before we can actually go on to the terminal portion of the operations when we finish placement of the facial allograft on the recipient. Although we only get to practice half of the operation in a procurement exercise, it's incredibly instrumental, it's incredibly educational, and it confirms to us that this operation can be performed and that the vascularity of the proposed transplant exists. We've taken advantage of every possible technology. And in the field of reconstructive microsurgery, the concept of computerized surgical planning, the ability to sit in front of a monitor, to think about a patient carefully without being rushed to the operating room, has been very beneficial to our patients. There has been a tremendous amount of publications, not only in the orthognathic surgery literature, but also in the reconstructive microsurgery literature. And we were able to take advantage of this technology for facial transplantation. These types of engineered or patient-specific cutting guides were used in every cadaveric rehearsal and were actually utilized during the research procurement, and finally used during the day of the clinical phase transplant. Truly remarkable tools that were beneficial for the final result. Another very instrumental tool is the utility of intraoperative vascularized imaging, in this case indocyanine green, through SPY imaging. We really want to ensure that the facial allograft is completely vascularized. For example, in the second case that I performed on the burn patient, the donor had a craniotomy incision on the right scalp. I did not want the recipient team to remove the recipient scalp until I had complete confirmation that the scalp of the donor was completely vascularized. And that's where we see great benefits from this instrumental piece of equipment. We've also looked at how we are involved with transplant teams that have to procure life-saving organs. This is a whole new field for plastic surgeons, and ultimately we have to perform these operations in a manner that will not only be safe for our patients, but for those patients that will be receiving life-saving organs. And we've designed algorithms for the procurement of a face allograft as well as a multi-organ procurement. I found it to be incredibly beneficial to have constant communication with all the solid organ teams, not only the cardiac, thoracic, but also the abdominal teams. And we've gotten to a point now that we can perform this in a manner as we did in our last operation, that all the surgeons were able to come in at a very precise time, and my procurement time with our team was only off by about 10 minutes. That not only provides maximal safety, ensures ideal procurement of the life-saving organs, but it also ensures that we will continue to be involved in this field in a responsible manner. The article that we're highlighting here was on my first patient at University of Maryland, total face, double jaw, and tongue transplant. This patient, who's known publicly, Richard Lee Norris, had undergone numerous operations for numerous years. It's a self-inflicted gunshot wound and an injury that I've personally struggled in reconstructing. The deficiencies have been not only in improving the appearance, but more importantly in the functional deficits with conventional surgery. This was completely dealt with the face transplant that we performed in 2012. Complete transplant of all the facial soft tissues, the midface, the maxillary teeth, the mandible, the teeth, as well as a portion of the tongue. The next article highlighted the patient who had a complete facial burn, and he had undergone over 81 surgical procedures. The primary motivation of his transplant was to provide ideal corneal protection. The individual was completely limited to being homebound, and he lost the ability to drive and care for his kids. The only way that we could improve his eyesight was to provide normal functioning lids, and that was the primary motivation. While we're at it, if it were ideal to be able to replace the entire face as well as the scalp and the ears, this would be the ideal goal, and we were certainly able to do this. And the patient still doing very well 3 years out from his transplant in 2015. The field has advanced greatly, and there are numerous groups throughout the world, and I'd like to highlight a close friend of mine, Laurent Lantieri, who was a mentor and a person that guided me and helped me along the way through my process. But in this retransplant of one of his patients with neurofibromatosis, it highlights the importance of the potential for chronic rejection in these patients. And this is one such patient who developed chronic rejection and received a second transplant. This is the only case of its kind to date that's received a retransplant following failure of the first face transplant secondary to chronic rejection. When we review the international experience, there are numerous countries that have been involved in this process, and we try to communicate closely, whether it's through scientific publications, through organized meetings, and try to benefit from each other so that we can continue being involved in this, what we consider a remarkable scientific field within plastic surgery. And you can see listed here the number of countries that have been involved throughout the world. With this, there have been significant challenges, and I do think that we can provide some insight with regards to the future directions of this field. The primary limitation of this field persisting is the medication requirement. With that, the potential compliance of patients, and if we can limit the toxic doses of toxic effects of immune suppression, that would be ideal, and this would hopefully become a standard of care operation. With my second patient, in other words, my first patient at NYU, based on very selective donor criteria and very specific patient matching criteria and patient-specific regimen of immune suppressive medication, including rituximab. And the reason we use rituximab, the patients had a very strongly positive cross-match to B cells and induction therapy with thymoglobulin. So far, the patient has been rejection-free. And if we know that if we can limit the episodes of acute rejection, hopefully we can limit chronic rejection, and ideally we can reduce the medications and therefore their toxic effects long-term. Another important article is the importance of increasing donor awareness, hopefully limiting the potential donor shortage, which not only is available for solid organs, but you could only imagine how the limitations could affect facial transplantation. In this one publication from our institution, we were able to confirm that through a very short educational video, we were able to increase the potential for face donation by 20%. And it highlights the importance of educating the public on the potential benefits of facial donation, which is really no different than solid organ donation. Public perception of face transplantation is something that we've looked at carefully. And in this article, Perceived Aesthetic Outcomes of Face Transplantation, a survey of the general public, there were 250 participants involved. And what was immediately obvious was that the results highlighted to participants of those patients that received a face transplant were highly better than those patients that had undergone conventional surgery reconstruction. And it shows the importance of education in this entire process to move forward with this field. This map of the country shows numerous programs that exist, most of them within the periphery of the country. And you could only imagine all the patients that exist within the central portions of our country. With this, it's important to outline how would long-distance care present itself for a patient that, for example, may live in North Dakota and has to undergo a face transplant in Minnesota. How do we overcome these hurdles, especially when there are very tight limitations where a donor may be available for a procurement of a facial allograft and by the same token not compromise the timelines of life-saving organs where patients are expecting those organs, and looking at the ability of transporting recipients from their home state to the location of the hospital where they'll be performing the face transplant is very important to evaluate. I'd like to highlight our close friends in Boston and Bo Pomahawk's group for looking at the quality of life after face transplantation, the outcomes, assessment tools, and future directions. As a group, we really don't have the best tools to evaluate quality of life measures. And they looked at numerous quality of life measures. And although we know that subjectively patients do feel better and the quality of their life has improved, it's important that we qualify these measures with ideal instruments. We currently don't have that ideal instruments, but I think most of us are trying to develop a very instrumental tool to measure the quality of life. Patient recruitment has also been an interesting process, and Dr. Pomahawk and his group in Boston have also looked at a single center's experience. And their experience is close to a 50-50 split of how the patients got sent to them. Many of the patients were referred by themselves, but a lot of other patients were also referred to by surgeons. And it also highlights the importance of educating our surgical colleagues as well as patients in potential need of a face transplant who could benefit from this type of operation and who just needs conventional state-of-the-art reconstructive surgery. We're often asked, what's the benefit of undergoing this procedure and what are the costs? The Boston group also looked at this carefully in one-year comparison of those patients that underwent a face transplant or those patients that underwent conventional surgery. It is clear that those patients that undergo conventional surgery, it's financially beneficial. However, when you look at the severity of the injuries of those patients that underwent a face transplant, it ended up being equal. But more importantly, patients that undergo a face transplant can eliminate the deformity within one operation. Those patients that require conventional surgery commonly need lifelong procedures. And that's been my personal experience. In a manner to evaluate those patients that would benefit from a face transplant, to evaluate deformities, and to help us communicate as this field was starting, I wrote an article in 2013 that helped me qualify or classify those patients at that time that had received face transplants. And it was very difficult to organize what type of procedure should we perform. But looking at the soft tissue deficits and looking at the skeletal deficits, this was a very simple way for me to help understand the types of operations that I would be performing on patients dependent on the type of deformity that existed. We always try to publish on the results of our outcomes. And although most teams don't publish their results in a scientific format, we looked in this article even at media publications to try to quantify the number of procedures that have occurred throughout the world. And even in this particular article, we have to appreciate the fact that these operations are challenging. And even with all these numerous operations, 6 patients have died from these operations. It's important to learn from our mistakes to be able to communicate so that we can continue to improve the field. Lastly, I'd like to highlight our last patient. This was a patient which is publicly known who sustained significant facial injury following a self-inflicted gunshot wound. He went through a very thorough process at our institution, which is IRB approved, was accepted as a patient, and was eventually waitlisted. There is no way that I could have ever improved the appearance of this individual, but more importantly, the functional deficit without a face transplant. And he underwent a partial face transplant, also including the midface, the maxilla, with the maxillary teeth, the mandible, the mandibular teeth, the floor of the mouth. And this case highlights the benefits that we as a group have been able to gain from the constant education, the constant evaluation. How is it that we can improve the quality of the results and at the same time hopefully extend the quality and quantity of their lives by limiting the toxic effects of medications? Although we have a lot more work to do, I think we're headed in the right direction. This is not possible without the support of a great institution, without the support from the Department of Defense. And in this particular case, this is the first case in the country where a face transplant was financially supported by a commercial third-party payer. But this team is not only supported by our dean and CEO and by a chair of our board of trustees, but it also includes our core faculty, the core surgeons, our anesthesiologists, the nurses that are involved in the team. But one thing that I'm personally proud of are the residents and the fellows that are involved in the daily care of our patients, and they're invited to be in the operating room to learn from this experience. That's why we're in academic medicine, because ultimately they're going to do it better, they're going to do it faster, and they're going to do it smarter.
Just a reminder, you can access all the collections of articles that we put together for free on prsjournal.com. We're going to head to the question and answer component of the evening. We're getting a lot of questions. About 5 or 6 different people talked a lot about funding, and you had touched upon that. Specifically, people are asking who's funding it and where do you see this changing in the future?
It's a very good question. It's a question that we're commonly asked. As we highlighted in this particular case, most of it was actually covered by commercial insurance. We do have support from the Department of Defense. The institution also supports this program, and we also have individuals that have been very generous to support these types of patients. But I do foresee that in the future, this is going to be something that will, ultimately be supported by commercial third-party payers.
Great. And I just want to introduce Rami Kantar, who's been a tremendous help in making this night happen. We're going to go through the questions together. So Rami, what's the next question that you have for Dr. Rodriguez?
So thank you very much for the opportunity to participate in this amazing grand rounds. Our next question is from Dr. Rorik, who congratulates you on all of your achievements and on advancing the art and science of plastic surgery, and asks you what the next step in advancing the field is.
Well, one of the great benefits, and thank you, Dr. Rorik, first of all, for the opportunity and for the question. I think what we've seen already, if I compare this patient to the first patient that I performed in Maryland, it resulted in significant reduction of operative time from 36 to 25 hours, significant reduction in hospital length of stay, ICU stay, rehab. I do think that we can continue to improve and reduce the operative time, and that happens through experience, maximal efficiency. I think we can reduce the hospital length of stay. There's no question that we can perform this operation technically. It's within our wheelhouse as reconstructive plastic surgeons. I think it's just the primary limitation is working on the medications. And I think our relationship with our transplant surgeons and our transplant immunologists is heading in that direction. One of the things that I've personally learned is how to define acute rejection. Even in our first patient, what appeared to be rejection, which actually was treated. And if we could avoid acute rejection, that would hopefully limit some of the medications, which we obviously have to supplement when a patient's going through this. In my second patient, and now this last patient, what would appear as acute rejection, typical erythema and edema, and although we biopsied it, and it looked like it had a Banff criteria rejection, by just watching the patient and not treating the patient, it actually resolved. So I think we have to really define what is acute rejection. The benefit of a face allograft is that we can look at it, and we have the benefit of time. We have the luxury of time. But if we can slowly continue to reduce the medications as we've done in our last patient and will continue to do with this patient, we can hopefully limit the toxic effects. And with that, I have to say that my first patient who underwent a face transplant in 2012, unfortunately, because of the consequences of medication, is in renal failure and is being listed for a kidney transplant. But I do think that the surgical practice will continue to improve, the hospital length of stay will continue to improve, the time of the procedure will continue to improve, and the medication regimen will also continue to improve. So I think it's a bright future for us, but we have a lot more to improve.
Next question is from Erica Lee. Thank you for the inspirational talk, Dr. Rodriguez. Could you please speak to the speech outcomes of recipients receiving jaw and tongue transplants?
And that's a very good question. And I think it's important to recognize that when someone gets a face transplant, we obviously think that everything's going to be perfect. And I've had my own personal struggles through my three patients. The first patient in Maryland in 2012, we did replace a portion of the tongue. But although I replaced that portion of the tongue, when you replace jaws, teeth, lips, to put that entire mechanism to work together, although it was better at the beginning, without constant speech therapy and without constant work, it's difficult to make it ideal. And I really wasn't as satisfied with the ultimate results of my first patient's speech. However, if I compare his speech prior to the transplant, it was far worse, but I would have expected better. In my second patient, the burn patient, it was primarily a soft tissue transplant with some skeletal subunits. What I did not expect is that following the resection of the burn tissue from that patient and from proximity of dissection to hypoglossal nerves, nerves that are important for speech and function, and also replacement of the lips, he developed a remarkable speech impediment and also had some great difficulty with swallowing and eating, something that I would not have expected. His speech ultimately came and improved and came back to baseline. But now we look at our third patient, Cameron. Every time I have an opportunity to evaluate him, he continues to improve. His speech is far better to compare to time of injury, but we also look at different measures. We do, at our institution, facial tracking. We specifically measure the quality of their speech as intelligible or unintelligible, and this is performed by speech therapists. And we're also looking at functional MRIs, looking at centers of identity, and also centers of motor recovery throughout the face. We still have some more room for improvement. With every transplant that we perform, we learn something new, But I don't know if these patients are ever going to speak 100% ideal, but I think if we can get them to 80%, we've done a satisfactory result.
So our next question is from Dr. Francesco Egro, who is asking about what is the expected hospital length of stay for these patients, and when can these patients be discharged home after the procedure?
It's a very good question, and it's a difficult question to answer with a simple number. And the reason for that is that every patient has a different deformity. Every patient may have different comorbidities. But I think it's probably going to get to a point where it could be 30 days for the hospital length of stay. Now, the Boston group has been able to discharge some of their patients far sooner. It's difficult to put everyone under one criteria. It all depends on the individual, and it depends on the type of transplant. If it's a soft tissue transplant alone, I think those patients could be discharged sooner. When it involves underlying skeletal structures, teeth, tongue, floor of mouth, it's far more complex. And in my personal experience, having those patients in the hospital and witnessing complications that we could address during their hospital stay is very important. I think the soft tissue face transplants will obviously stay in the hospital far less.
That's great. Some questions from some residents across the country that are interested in pursuing this avenue in their training. What is your recommendation for somebody who's interested in pursuing this?
Well, first of all, you got to be dealing with the typical problems. And these are problems that all residents deal in any academic institution, whether it's trauma, getting experience with skeletal reconstruction, soft tissue reconstruction, being involved in reconstructive microsurgery, head and neck microsurgery, and also aesthetic surgery, because these are, you really have to have experience in all these different fields: craniofacial, microsurgery, and aesthetic surgery. But moving forward after residency, I do think it's important to get additional training in a fellowship, particularly at a place that may be performing face transplants. We've had the unique opportunity where our residents get exposure to these types of patients, the operations, and our fellows have also been involved in the cadaveric rehearsals, research procurements, but I think that's the direction that one can take. There are limited centers in this country, but I'm sure that you can gain additional experience through these centers, but also through becoming very well versed with the literature, the body of literature that exists within the Journal of Plastic Surgery. I think it's the premier journal. It's currently taking the primary position of these remarkable publications that allows us to understand the field of facial transplantation better. Ultimately, you're going to be a constant student, as I am.
So our next question is from Dr. Sami Sino, who is inquiring about what is your impression or your take on management of the brows based on your research and on your clinical experience.
Sami, thank you for the question. When you look at the patient that I just did, if you look at the position of the brows, but more importantly, what ties into the brows, the nasal orbital, ethmoid region, the attachment of the canthi, and I was actually quite impressed that following the recreation of the defect or the removal of the injury, that the brow position was able to go into a more normal location. But I think that's just the removal of the injured tissue, the inflammatory process, something that we've learned from the trauma literature. Now, if I look at my first patient where I replaced the entire forehead and the brows, the one thing that I learned there was that patients that are immune suppressed, I didn't have the ideal suspension of that tissue. And then I would probably consider in the future, if I were to replace a forehead with the brow, I would probably include skeletal segments for optimal retention within the cranium. Because in my first patient, even within a short period of time, a month or two after the transplant, he developed complete brow ptosis. And we know that patients that are under immune suppression really don't have the most ideal wound healing process, and therefore the attachment of the fibrosis of the tissues doesn't exist. And that's why I've included bony segments within the facial allograft to hold the soft tissues in their ideal position. So I think the inclusion of bone with the forehead or the brow to maintain its ideal location is probably going to provide some great benefit.
Our next question from Sturgios Dumas, amazing presentation from the leading authority. Do you reckon there'll be an option to reconstruct head and neck cancer patients with allotransplantations?
It's an immediate concern, but I think there's going to come a point where a patient may be cancer-free for greater than 5 years, that we may consider it. We've learned from one case that was performed in Seville. That patient underwent a transplant following not an immediate oncologic resection, but within a reasonable amount of time, and that patient did develop a recurrence. So it's something that I would be very cautious. I currently do not feel comfortable to perform a face transplant on a patient that has a history of cancer, but it would depend on how long they've been cancer-free. Please be mindful that some of these immune suppressive medications like calcineurin inhibitors do make patients prone to malignancies, and that's why we're very cautious with cancer patients.
Our next question is from Tariq Al-Jindi, who is asking if any of your patients has received cell-based therapy, and if yes, if it has helped with preventing or overcoming rejection.
Now, I'm not entirely sure what the question may be with regards to cell-based therapies, but one thing I can talk about are the different protocols that have existed, whether it's bone marrow transplantation as defined by the Pittsburgh protocol, something that we do not perform. We were kind of on the line of including vascularized bone marrow with the facial allografts. Now, when we try to measure donor cells within the recipient bloodstream, what we call chimerism studies really hasn't panned out, and we haven't been able to define not even microchimerism in these patients. That may just mean that we don't have the right assay, or we really don't know what we're looking at. So I think the literature really does not support one system over the other. We hope that the inclusion of vascularized marrow may provide benefit, but the reality is that bone marrow infusions or vascularized bone really have not shown any benefit. So we're still looking at that, and we hope we can look at it a little bit more intelligently.
Another question is about the donors, and you touched upon this in your talk. How do you find donors? Do the donor give approval prior to death, or does the family decide after the person dies? What's the consent process?
The donor process is one that I'm very much supportive of the way we do it. When a family consents to solid organ donation, and first of all, it's a great opportunity, all of us should be organ donors. We first respect the patient's wishes, but ultimately the family can decide whether they want to consent to donation. Normally, if an individual is deceased and they're an organ donor, in my experience, the family does consent to donation. Once the family consents to solid organ donation, then we approach them secondarily for facial donation. And I think that's important because I would not want the requests for facial donation to potentially compromise life-saving organs. But we've trained transplant coordinators to present that to grieving families. Are they willing to donate the face of their loved ones? It's not something that we present to every patient. We do try to get some information to ensure that they are a potential match for our recipient, because we would not want families to be approached with this request and then have them find out that the face of their loved ones was not usable for our transplant. And that could also be quite a difficult process. So it's a process that we approach secondarily, and we've educated people within our organ procurement organizations to approach the families. And then the families do have the potential to have me come on site, if they wish, to explain the process further, which has happened, and it has been helpful.
Our next question is from Jignesh Unadkat, who is asking you about your approach to management of the nerve cooptations, given how important functional outcomes in face transplant recipients.
Now, I've benefited greatly, and it's a wonderful question. The nerve function is very important. I benefited greatly from the Boston group in that they did their nerve coaptations closer to the target muscles. I used the same approach in my first patient at Maryland in 2012 for the facial motor nerves. Now, I was hoping I would find the same with the sensory nerve, but in a patient that had ballistic injury, I struggled identifying V1, V2, and V3, and therefore I did not perform those coaptations. The facial nerves, I did identify them, and I'll tell you it was rather tricky in a patient that's undergone ballistic injury because they have a tremendous amount of synkinesis, and it's very difficult to really separate the branches. It's not like a typical parotid dissection where you identify the nerves, but the goal would be to follow the Boston protocol, which is to go as distal as possible to the target muscle, and that would also limit the amount of time required for recovery. Now, what I've learned in patients that have exposure to calcineurin inhibitors, they do have a pretty facile recovery, and that literature has been published by Sue McKinnon from WashU in St. Louis, and that's been our experience. Now, whenever possible, we do try to find sensory nerves. In my last two patients, I did connect both V2. They did regain some recovery, but not 100%. But I think that's a struggle, the drooling and the inability to feel their lips. So I think trying to find some target, at least for V3, is very important.
Our next question is from Nikki Phillips, co-resident ambassador from the Harvard Plastic Surgery Program. She's actually in Australia now watching live. She's doing a fellowship there. She says, I think our audience may be curious to know, what should someone who thinks they know a candidate for this procedure do? How can patients find you or other centers that perform this procedure?
Thank you for the question. I think what's most helpful when you identify a patient, if you're out there, wherever you may be, is to try to define the deformity, of which we do have limitations with conventional surgery. But the anatomic criteria is not enough. It's also beneficial to try to understand the mental health of the patient, level of responsibility, and also the potential level of compliance with medication. And that's something difficult, something that we personally struggle. Although we evaluate these patients, and I commonly go to their hometowns and try to look at the support systems, it doesn't matter how vigilant we are, we really don't know what's going to happen once a patient receives a face transplant. We want to make sure the patient's mature, responsible, and will be compliant. But I will tell you from my personal experience, my first patient was not as compliant as I would expect it. And we've also seen this in the solid organ literature. Even patients that are heart recipients may not be the most compliant. So I think defining the anatomic deformity that we cannot reconstruct with conventional measures, and that's why I look at the central face deformity. It's very difficult to reconstruct lips, to move and have sensation like lips, eyelids. Those are very difficult areas to reconstruct. But then after that, the type of individual, level of responsibility, the compliance. But with that, if you identify a patient that could benefit from a transplant and seems to be a reasonable candidate, what I do advise teams and surgeons is to potentially limit surgeries that may not be helpful, because ultimately those patients may receive transfusions, which makes it difficult to cross-match them because we're introducing numerous antibodies. So I think whenever possible, you identify a patient that may benefit from this type of operation, reach out to your nearby facility and try to present some of the information to the surgeons that are performing it to see if this is a potential candidate.
Okay, so I think this brings us to our last question from Dr. Jordan Fry. Dr. Fry is asking about what are some of the most notable unexpected obstacles that you have encountered in the treatment of your 3 patients?
It's a great question, Jordan. In my first patient, when I placed the allograft, which included the maxillary components with the teeth and the mandible with the teeth, when you recreate the defect, and when you look at Richard's case, basically had the condyles and the component of the ramus. And when there's nothing there and you put the new allograft on, I pushed the lower jaw as far posterior as I thought it should go, so that the condyles would be at the posterior aspect of the fossa. And in hindsight, when I evaluated his case, when I looked at Richard's CT scans, prior to his transplant, his condyle had been out of his fossa for about 15 years, and then I pushed it back into the fossa. So what ended up happening, he ended up developing a class 3 malocclusion, which actually worsened his speech, and it made it far more difficult for him to eat. And then I was trying to figure out how to go about and corrected this. And I put him in orthodontic appliances. It didn't help. And ultimately, I had to push forward. I evaluated and brought him into the operating room. I elevated his coronal flap. I looked at the midface. I looked at the plates, and I thought, could I potentially move this midface? So I ended up redoing a Le Fort 3 osteotomy, pushing the face further forward to put him in a class 1 malocclusion. But I did not expect that. But I could have avoided this if I would have just kept his condyle in the position that he was premorbid, which for him was outside of the fossa. With the second case, the firefighter, the transplant, which included the entire scalp. At that time, I wanted to avoid pressure to the posterior scalp. And I had learned from Laurent, from a patient that he had performed in Paris, that the patient developed a significant amount of posterior scalp necrosis. And I was concerned about the potential tissue necrosis to the posterior scalp. As a matter of fact, I had engineered a halo used for cervical spine injury to secure the head. When I transplanted the face on our firefighter, the amount of edema of the entire scalp and the forehead was so sizable that I could not even fit the halo. But one thing that I learned right there and then was to preserve some of his own posterior scalp, which had sensation, and therefore avoid the primary union at the midline, and I kept a good amount of tissue, of his own tissue, as a triangular flap, and then I left the excess tissue on the side, giving him the opportunity to wake up, edema to subside, and then I brought him back to the operating room days later, and I went uniting the posterior scalp. In our last patient, the most valuable lesson, when you're preserving the tongue, but when you're transplanting the lower jaw with the floor of the mouth, and you could imagine when you look at the mucosa at the junction of the mandible, the lingual mandible, with the floor of the mouth, the tissue is paper thin. And although I took a significant muscle cuff of mylohyoid and all of the digastric musculature to help me seal the floor of the mouth, within days after the transplant, as I was plugging the tracheostomy to get him breathing on his own, he was developing significant anxiety at night. And when I evaluated him, I thought he was just nervous, but what really ended up happening is that the floor of mouth was dehiscing, his tongue was pulling back to his premorbid state, and we had direct communication from the floor of the mouth to the carotids. And what I've learned, if performing that operation again, we do have to suspend the hyoid and the sublingual musculature to the mandible, which is what I ended up doing as a secondary operation. And hopefully this publication will be accepted to the Journal of Plastic Surgery, and it should list all the challenges that I had and how I benefited from and how I solved these problems.
We'll do, I think, 2 more questions. There's a lot of international viewers. We have from Asia and from South America, and they're asking, where can they go to get exposure to this? Who's sort of willing to allow them to get training in this? What type of advice would you have for them?
I think the best advice I could give you is to look at our publications in the Journal of Plastic Surgery. In the journal, we've been able to publish not only our experience, but in the Journal of Plastic and Reconstructive Surgery, we've also published videos that highlight the surgical procedures and the important components of the case. We've also included cadaveric rehearsals, because it's very difficult with the limited number of cases to be at the right place at the right time. But as I mentioned earlier, being involved in facial reconstruction, understanding craniofacial operations, understanding aesthetic surgery and reconstructive microsurgery prepares you to be involved in these type of operations. It's no different than the inception of all major advances that have occurred in our field, whether it was craniofacial surgery, reconstructive microsurgery. But if you have a chance, you should visit those places that are involved, and hopefully you can gain additional experience. You may not be able to see the actual procedure. We've had an opportunity where we've had international visitors be at our location during these specific times, but not every visitor has had the opportunity to benefit from this. But I think being a constant student is going to prepare you to perform these types of operations.
One last question that we have. What's it like the moment when the face transplant recipient looks in the mirror for the first time? How can you describe that, if it is even describable?
Yeah, I think there are numerous moments that are highly emotional. When performing the face transplant and you finally open up the clamps and the face receives blood for the first time, that's an incredibly emotional moment, although you still have many more hours to operate, but at least you know that this facial allograft that now lives on this recipient, of which it will be his or hers, now is receiving blood. But until the patient looks in the mirror for the first time, you don't really know what to expect, which is no different than any other operation that we perform. It doesn't really matter what we as surgical teams feel about our result or what we think our result may be. It ultimately comes down to what a patient thinks. And if that patient is not satisfied, it could be devastating. But when a patient looks at themselves for the first time and begins to evaluate normal anatomy in their face, which is important to help us identify and define identity, I will tell you that it is highly emotional. Even though being involved and being a scientist and being a surgeon, it's very difficult to put aside the human emotion when this patient's surrounded by his loved ones and is seeing a normal face for the first time. And I will tell you personally that I gain great satisfaction being involved in this field, as all of us do, because we gain great satisfaction for caring for our patients.
That's great. Just a reminder, the articles are again on prsjournal.com. Look for the PRS Grand Rounds icon to access these articles. This lecture will be archived, and feel free to share it with on your own personal social media outlets. Once again, thank you so much to all the participants. A special thank you to Dr. Rodriguez. We really appreciate it. It was an outstanding lecture and a great question and answer forum. Thank you so much. And thank you again, Rami, for all your help for this evening. And we look forward to all our future endeavors with the journal.
I want to thank Iris Savetsky and Rami Kantor for making this possible. Without them, it wouldn't have been. And I thank Dr. Rorik once again for this remarkable opportunity. Have a good night from New York.